Heidi Elnimr, a PhD candidate in Vienna University of Technology, and in the last phase of my thesis. This article is just one of my research dissertation objectives, a study of architecture barriers and the potential role of the assistive technology in long-term healthcare centers for people with Alzheimer's disease. So we are focusing on this paper, on this study, to know the people with Alzheimer's disease needs and considering them the main, actually the end user. And considering them as the end user. This is the main focus of the study. And also it's important to read the paper because the literature in this part, especially for the room, the people with Alzheimer's disease room, it's in the long-term healthcare center, there is not much literature in this part. So allow me first to define the Alzheimer's disease from the people with Alzheimer's disease perspective, which it will be a little bit far from the medical definition. It's for them, it's always a question about how to and where to, how to do this activity and where to do it. By time, people with Alzheimer's disease is just losing their this information and losing their sense of the spatial. Unfortunately, Alzheimer changes one's relationship with the space. And in this direction, and for better understanding, in-depth understanding the relation between the people needs and space and the potential role of the assistive technology, this study has three main factors. The first one, the people with Alzheimer's disease as an end user, and started to know what their fundamentals activities in their rooms. The second one is assistive technology, just knowing what's the type of assistive technology they are using in their rooms at the long-term health care center and for what reason. And third aspect is to configure out where is the architecture barriers, which considered as an obstacle to achieve their daily activities individually without the carer's help. So the study had mixed methodology with a sequential design, a quantitative study followed by a qualitative study. The total participants were 30 professional experts working in the same Alzheimer's center and in a daily contact with the patient with Alzheimer's disease. In addition, in one patient or one resident with Alzheimer with the early stages of Alzheimer for shadowing observation. From the results, for the first axis, we can define there is a daily routine for them, the same sequence every day, and the same sequence is reversed at nighttime. They are getting out of the bed, going for self-hygiene or the toilet, then the wardrobe changing, and then this sequence is reversed at the nighttime. For anyone, a normal people, this sequence is really easy actually to achieve, but this consider one of the challenges to be achieved by the people with Alzheimer's disease without the carer's help. Concerning the assistive technology they are using in the patient's room, so there is two types. The first one is preventative technology to detect the patient movement, especially at the night time. So they are using sensor bar or a carpet sensor, and the other one is to, if the patient needs help, so he has to push the button to which is connected to the nurse station. But from the interviews actually and from the shadowing observation also, most of the time patients forget to push the button and getting help. During the shadowing observation, I noted that the patient is always getting close in this point for some reason. He is always has a problem for self-orientation in his room in this point, losing his orientation, just only facing this corner and losing everything, just stopped, postponed always in this point. And to know what is the architecture barriers, we need something to compare with the layout and the room's equipment. So I compared the layout of the room and its equipment by the therapeutic environment's main factors. These main four factors should be integrated and implemented in the therapeutic environment if we need or wanted to make it as a friendly, interactive therapeutic environment with a positive outcome on the patient. So by analyzing the room layout according to these main factors, we can define that and determine that the architect just taking one aspect in his consideration is took the fundamental equipment of the room, while in the same time he just missing the other three factors. He didn't consider the patient as an end user, and he didn't take in his consideration the current health status of the patient. In addition, he didn't take in his consideration also the patients now needed to be guided and directed rather than to take a decision from multiple choices like the doors in front of each other. Additionally, there is no clear visual access to the room layout to the patients. There is a hidden corner, and this hidden corner, unfortunately, had contained these three doors with the same color facing each other without any sign to clarify what is behind these doors. So that's one of the reasons why this patient is getting lost or losing his self-orientation in his room, because of confusion, which this kind of design is causing an anxiety and uncomfortable feeling for the people with Alzheimer's disease in the living area they are using every day and every moment, and spending more time in it. So there is two essential questions just popped up in this stage. How are architects enhancing the existing therapeutic environment, and what design strategy could help improve the therapeutic environment of people with Alzheimer's disease? The answer was the user experience design concept and why it is suited to make the friendly therapeutic environment for people with Alzheimer's disease, because it focuses on the user's needs, abilities, limits, and what they value. And this is exactly what the people with Alzheimer's needs and wanted to find in their therapeutic environment. Someone designing the therapeutic according to their needs, according to their limits, and according to their ability, according to their current health status. But here there is another problem, how we can implement it in this design concept in the existing building, which is creating and supporting the self-orientation of the people. How we will give them the missing information they wanted and they needed to achieve their daily activities in their room without the carer help. And here comes the answer with the assistive technology. Assistive technology can provide a connection between the people with Alzheimer's disease daily activities and their surrounding environment to create an interactive therapeutic environment that supports people with Alzheimer's disease self-orientation. Assistive technology is any device or system that enables people with Alzheimer's disease to accomplish tasks they would be unable to perform. So assistive technology includes a wide variety of devices that, according to their purpose, can be divided into three main groups. Supportive technology for helping people with Alzheimer's disease to complete tasks, responsive technology for managing risk and raising the alarm, and preventative technology for preventing harm and raising the alarm. The three assistive technology group could be applied and implemented in the people with Alzheimer's disease room, or in this current case study, to reveal to reveal this hidden corner and making like some kind of partial solution for the people to self-orientation. Depending on what had been clarified to create a therapeutic environment with a positive outcome, this study recommending the following. Shadowing observation is essential to understand in depth people with Alzheimer's disease needs and to understand what the architectural barriers they are facing. Secondly, user experience design concept suitable to create an interactive therapeutic environment with a positive outcome for the patient. Assistive technology has three main rules. First, it can be reveal the missing information and reshaping the therapeutic environment and creating a supportive environment for people with Alzheimer's disease activities. And after a while, because of this research, I made it during the pandemic, which was really harder to follow up the interviews and making the shadowing observation. There is a development using the assistive technology as for the shadowing observation and collecting the data. So there is a several sensor could be used to develop this shadowing observation and analyzing all the data. And by comparing the shadowing observation by the researcher and by using the sensors, there is lots of pros and cons between using both of them. But if we need to continue the research, so we have to apply the sensors and using it to complete any research in such a pandemic or something. This is one of the things I face it in during the making the research.
When you mention that you're trying to go for the needs of a person with Alzheimer's disease, and you find that assistive technology can be a solution. But once again, when you install, considering that, well, they lose the notion of space and other things with this disease, when you decide to go for a specific solution of assistive technology, what kind of guarantees do you have that installing it with a specific configuration, it will be a solution for all? I understood you do shadowing observation. Is that the way to try and get it right for the maximum number of people with the Alzheimer's disease to solve a specific situation? Is that the idea?
Yeah, this is the idea, but we can't make this one design fits all. It's not working with the Alzheimer because it's individually actually designed.
Okay. I think
framework. So now we are collecting the data for individually. Then after a while, we will have all of this data collected and making in machine learning for self-learning and all of this stuff. So everything will be developed in the future by time. But one design fits all is not working.
Okay.
I am just working on one symptoms with its self-orientation. So this is, we are making a defining with the symptoms, not with the disease in general itself. Not all this will not fit everyone.
Okay. So the shadowing observation is very individual, right?
Sure, it should be individual. Are making an interactive therapeutic, it's not possible to be a general. So it's a general framework, but to implement it and decide which assistive technology will work out. So no, it will be individually. Some people might have interact with the voice, some other will with a visual light, something with the signs. So it's I can define, yeah, this one design fits all for the assistive technology. No, it's really hard to now to say. But in the future, we can just making it collecting this data one more time by using the sensor, while the people are using some kind of assistive technology like the interactive radar for something and displaying this information. Then the sensor will remain in the room to detect the people movement. And by detecting this movement, we can analyze if they are interacting in the right way or it's not the right way they are interacting it. After a while, we can take this all data by machine learning algorithm and making a defining with the machine learning. If we have these symptoms and with this action, we can say recommended this kind of assistive technology. But will take more time because this is something new still in the field. The most studies already and prototype in the private houses, but not it for me because people are staying there more in the private houses. So why we are not implementing it in the long-term healthcare center for now? Because of the budget, maybe, because this is one of the question of the interviews. So some people said that, yeah, because of the budget, the other one, because lack of knowledge, because the company is offering just only the expensive assistive technology without of the budget of the long-term healthcare centers. So this two reasons, and the other one, maybe it will be from the ethics part, because it's harder to take the confirmation and it's hard to take all of this consent the approval from the patient or from the relevant to have this study to be made. So there is some obstacles to be implemented so far, but step by step, we can collect the data and improve this therapeutic environment and making it interactive and with a positive outcome for the people with Alzheimer's disease in the long-term healthcare centers, not only in the private houses.
Okay, thank you very much, Heidi.
Welcome.
Thank you, and congratulations for your work. It's marvelous. Thank you.
Thank you.
Thank you, Heidi. And just one small thing to add, that it might be unbelievable, but maybe some hospitals, for example, even don't have Wi-Fi. So there is a question of infrastructure, that they are not able to implement these fancy technologies we are able to offer already, because they just don't have the infrastructure to implement these technologies.
Yeah, exactly. This is the third paper. Actually, it had been submitted already. This is using the BEAM system, the building information modeling, to convert the normal therapeutic environment to interactive or a smart building. So because building information modeling have all the life cycle of the building. So if I wanted to implement this technology, so I will know where and how to implement it, because I have the life cycle of this building itself between my hands in that BEAM system. So this is the aim actually from the dissertation itself, to find firstly we defined where the problem and the needs, and because also of the lack of the nursing, this is one of the problem. So we need to use more smart activities, more smart building, more assistive technology, helping the people with Alzheimer for self-orientation. And when I discussed it at Alzheimer conference, the neurosciences actually recommended it, because when you are making a daily routine for a long term, the case is more stable for the Alzheimer's. So there is a lot of benefits for using the assistive technology in the long-term healthcare center, or using the BEAM system and controlling all these smart buildings through the BEAM system. So we can implement, we can change, we can take this data and analyze it directly for the neuroscience or occupational therapy, for example. So there is a lot of benefits if we are started to implement something like this. And I was lucky actually here in Vienna, because I started this study already in one of the Alzheimer Association, and they are really happy to be a pioneer in Europe, to have this study to implement it at their place. So we will start to using the sensor, and actually the 3D sensors, with using the infrared. So we know the outline of the patient, if this is a patient or this is a caregivers, and we can analyzing the YX data and the coordinates for the plan, so we can define if these people, this patient, have the problem here or there, or what with the equipment or the way, the layout or the colors. So there is a lot of alternative. We can discuss it later. Or so I'm really lucky to have this cooperation with the association here for Alzheimer. They are welcoming and to be a pioneer in this.
Thank you, Heidi, so
Welcome.
much. We just wish you a good luck, because it's really needed.